Good morning, everybody, and welcome to the next webinar in our coronavirus series. My name's Henry Elphick. I'm the CEO of LaingBuisson, so I'm delighted to welcome you today to our webinar on home care and supported living, and in particular in partnership with Addleshaw Goddard, the solicitors firm. And we're also working with Care Markets and with our two charities, the Care Workers Charity and Turn to Us. And whilst this is a free webinar, if you're able to make a small donation to either of those charities who are making small grants to people in real need at the moment, that would be hugely appreciated. Just before we kick off, just so you know, there is a website, LaingBuissonEvents.com, and on that we have all our upcoming webinars, but more importantly, we've got on-demand downloads of our previous webinars, including the slide deck, and again, an opportunity to donate to Turn to Us. So today we, as I said, are focused on the home care market. I'm going to set the scene by just looking at the Twitter poll that we've been running for the last week. And the question we had is, what will impact home care and supported living most? Will it be increased use of technology? More funding, perhaps from local authorities, easier ability to recruit staff, or better commissioning. And interestingly, you can see very much a focus on funding and technology. What we're going to do now is just encourage you to log into Slido, which is the tool that we're going to use to manage our polling, but more importantly, also our questions. So if you've got access to another device, or even on the laptop or tablet that you're on at the moment, if you just open up a browser and go to slido.com, it comes up with a box with a hashtag in it. And all you need to do is put in the word home care. And in a moment, I'm going to run that same Twitter poll that I showed you earlier, and we'll keep it running throughout the webinar to see whether people's views change as you hear from our speakers. But also it allows you to put in questions. But the key thing is it allows you then to vote on those questions that you want addressed most, because we usually get lots of questions. So the way of filtering it out is if the audience upvotes the one they're most interested in, we can then put those to the panel. And that works quite effectively. So if you've managed to open up that browser and to put in home care, hopefully you will now also have access to the polls, and I can see that 30 of you have already managed to get in there and do it. And you can see that technology is now ahead of local authority funding compared to the Twitter poll. And we will let that poll run during the course of this webinar, and I'll present it at the end because I think it's useful to see essentially whether people's views have changed. So what were the key themes? The questions that were posed to us by people who received the invitation were really around what will the new normal look like, and what lessons have we learned from this pandemic? And particularly as it relates to home care, whether there'll be a change in the operating model, whether the sector is overcrowded and how volume can be focused on fewer providers, how the sector, and this applies as much to supported living as well, will tackle the increases in minimum wage, and whether local authorities will actually pay for that. Will there be more support for the sector more broadly? What do we think the size of the market will be, and how will that be impacted by coronavirus? The status of care workers, and how reliable all the statistics are that we've been hearing so far, where, as you know, there's a lag time, and until recently, the Department of Health wasn't even disclosing deaths in care homes, let alone home care. Today, we are also tying this in with the launch of our home care and supported living report, and this is available on our website, also kindly sponsored by Addleshaw Goddard. So it gives me enormous pleasure to welcome our panelists. We've got William Lang, the chairman of LaingBuisson, also author of that report, to set the scene. We're then going to hear from Jonathan Vellacott, who's the executive chair of My Home Care and Complete Care. So one of the largest providers of home care and complex care in the country. And Jonathan is not only an operator, but a serial entrepreneur as well. Dr. Jane Townsend, who's the CEO of the UK Home Care Association, who's been incredibly high profile in terms of making the awareness of the sector much more prominent with politicians and the press over the last few months. She hasn't had a day off since February. This has been an incredibly busy time. Bhavna Keen Rao, who's the Managing Director of BKR Care Consultancy, which assists a lot of providers, particularly when it comes to inspections from the Care Quality Commission. And then last but not least, Tom Spears, who's a partner from Addleshaw Goddard, who will talk about some of actually the very new but very critical liability issues that are being thrown up by coronavirus. So on that, I will hand over to William to set the scene and give us some data around this market before we talk around some of the challenges today, but also what the outlook is for the sector going forward. William, over to you.
Right. Well, thank you very much, Henry. And I'm really looking forward to what people hearing are going to be saying today, because, of course, this is all a new world. Do remember that the market report that I'm giving you a brief summary of was written and researched before the coronavirus emergency hit us. It seems a lifetime ago now. So let's just look at what the market, this is what we're talking about with home care and supported living. So it includes extra care or housing with care. It includes, at the periphery anyway, home health care, which is now known as clinical home care, telecare and telehealth, and transitions from younger people to adults. But mainly it's about home care, including complex care and supported living. So that's what we're dealing with in this particular market report. So let's go on to the next slide. And this is about the market size, if we can have the next slide on. There we are. So here we are. It's, at least I think if you're seeing the same thing as I, it has a breakdown of the market into its different component parts. Home care at 5.5 billion, supported living 2 billion, and then it gives a figure for the England market as a whole, and the UK market, which gets up to over £9 billion. So that's the size of the market. So it's quite chunky, not enormous, but quite chunky, and a bit smaller than the care home market. Looking at the funding sources, and home care is, as we all know, rather different from supported living, because home care is primarily targeted at older people, whereas supported living is primarily targeted at younger adults, where the intimate care function is not involved so much. So the funding sources, we have the bulk of it still funded by the public sector, but there's a quite significant element of private pay in it. 1.5 billion out of the total of 5.6 billion. Remember, this is at England level, not at UK level. So that's a bit less than 30% is private pay. So that's for home care. And then if we go on to supported living, there it's much more focused on state-funded support, with the councils being responsible for the great bulk of the funding for supported living. And let's go on to the next slide, if we could. Now, this is something which is quite new to our report, new this year, for the first time, because we have the information being published in all of the CQC inspection reports. We know how many individuals each service is looking after. And so this provides a confirmation of the really long tail towards the left-hand side of that graph of micro businesses, which with an awful lot of them dealing with less than 10 to 19, very small business here, micro businesses. And then, but then if you look at the number of people covered, which is the yellow line, by entities or agencies of different scales, then it's not quite so focused on the small end, really. The modal size is around about 100 service users for each service. So that's some interesting new stuff, just demonstrating the fragmentation of the sector. The other one, this one here, is about the consolidated EBITDA margins for the major for-profit providers. And here we see what I'm sure people will be aware of, that when we came out of the, when austerity started around about 2010, there was quite a significant downturn in margins for home care and supported living providers, which we're just starting to move out of as new operators take on from the old failed ones, or the ones that have exited the market anyway. So I think that comes to the end of my slides. I'm not going to talk about technology, but actually there is one more, that's right, market potential. So first of all, digitization, and interesting to see that tech is in first place as the big changes are going to take place as a consequence of coronavirus. Integration of health and social care, will it actually finally move forward? Final thing is, I think, very important, which is equity of esteem and possibly funding for health and social care. And one of the things we've seen as time has gone on, the debate on coronavirus has become, it started off being very NHS-centric, and then it moved on to include care homes and even home care services as well. So as we are now clapping every week for the NHS, that incorporates also a clap for the other providers of care services as well. I just wonder, my concern is that this esteem that people have now for to include the staff providing services is actually going to hang over into the providers themselves, because there is still, I feel, a certain degree of suspicion, certainly within the public sector, of the independent sector organisation of home care and supported living, and indeed of care homes as well. And it's a sector which has been privatised over the past 40 years or so. So it'll be interesting to me to see whether attitudes towards not just the staff, but also the providers themselves change as a consequence of coronavirus. I'm not going to say anything more about tech because Jonathan, I believe, is going to major on that, so I'm not going to try and steal his thunder. So thank you very much.
Slido popping in at odd moments here, so I'm just going to try and so thank you very much, William. We seem to have Slido popping in at odd moments here, so I'm just going to try and restart the slides, and hopefully that will stop it. If I do that, hopefully we're uninterrupted, and delighted to ask Jonathan to set the scene in terms of a provider in the sector. Jonathan, over to you.
Thank you. I thought I'd just start by sort of just putting in sort of context the market and the number of people in each of the sort of sectors. At any one time, and these are rough averages, in hospital there's 120,000 people, in residential care we have 400,000 people, and in regulated health and social care at home, 820,000 people being looked after at any one time. And for me, that's quite important, because more people are living longer with an increasing number of underlying health conditions, heart condition, cancer, some form of dementia, and so on. And therefore, the demand for the whole of the health and social care sector is set to significantly increase. But we've got positive outcomes from medical interventions, which are obviously very expensive. And the relative value put on having a sustainable lifestyle for the elderly in particular, I think is something that is going to cost us more as a nation and needs to be factored into sort of long-term funding. But health and social care at home, as we know, is the poor relation and potentially the value for money option in the whole of health and social care, if we can sort of focus a bit more on delaying the demand for the expensive primary service, at the same time allowing people to live independent lives at home. And moving down to a little bit of an advert about my home care, going back a bit, Henry, to the bottom of the slide before. We have here, my home care is 2,400 health and social care professionals delivering health and social care to 3,250 people in their own homes. So my home care is a domiciliary care provider in England and Wales with a strong pan-London presence, predominantly state-funded with an increasing self-funder clientele. And we also have a dedicated living care offering through our Noble Living Care brand. Whereas Complete Care is totally health-funded. It's a leading nationwide provider of nurse-managed complex care at home for both adults and children, dealing with individuals with spinal injuries, brain injuries, and other neurological conditions. So very separate businesses, but all part of this main spectrum. And moving on to the next slide, how have we been resilient through COVID-19 and the pandemic? Fortunately, over the last 2 years, across all our businesses, we've made a significant investment in technology, whereby we entered the pandemic with a fully digital cloud-based operating model. What has been interesting is how quickly we managed to accelerate change of mindset within the organization and externally, sort of pushing the boundaries of how we normally work. We have managed to have people working from home, whereas the office culture was fairly strong, as it is in a lot of businesses. And all our care workers on the ground have had smartphones for some time. So the communication has been very strong as well. All other aspects of the business also have had to go digital. Our whole recruitment training model, in fact, in March and April, we have had the 2 best months over the last 12 months in terms of number of new applicants. A lot of them coming from other industries. Hospitality has been a very strong one as well. But without the technology in place, none of this would have been possible. And I now believe, and I'll come on to it, that we will not be rowing back from this position going forward. So what has it allowed us to do through sort of the pandemic? Consistent continuation of our care operations, very, very important. It's also the ability to absorb the shock, which was a huge shock. I remember those first weeks of March, really trying to get through all the decisions that needed to be made in order for us to continue of what is, if you think about it, a remote workforce out in the field, in particular on the domiciliary care side. So moving on to what we think going forward, the challenges we've had to overcome, delivering care to customers with COVID-19, not as straightforward as everyone would like. Some of the workforce have been scared of the unknown, which is fully understandable. We've moved towards having specialist teams of people within each geographical area looking after people with COVID. We've had a lot of staff obviously off with either symptoms or self-isolating or longer term at-risk people as well, which we've had to deal with. The press has constantly been full of the PPE issue. It's a real concern for all of us as providers, not only in the availability of PPE, the new PPE for us, using masks for every visit and so on, is something we haven't had to have the supply of before. And the costs, everyone has read in the press most days that the costs are 4, 5, 6 times. You know, those short-term issues could well become longer term ones, and it's an embedded cost in what we do, certainly for the next 1 to 2 years. And the other challenge has obviously been the low status of social care professionals, amplified by inappropriate commissioning models. For instance, a common trend has been in order to reduce costs that commissioners will only pay for the minutes you're in contact with a client and not for the whole time that you have to pay a care worker for. Some of that has thankfully been offset by short-term change in commissioning models from local authorities in particular, a little bit of enhancement in terms of the cost side, but changing to a paying on planned model has hidden that underlying costs on a short-term basis. So looking to the future, and moving on to the next slide, what do we feel needs to happen or is happening in the system? There is a greater will to create a sustainable social care, health and social care element within health and social care. I think that's very, very important, getting the balance right between the two in terms of recognition and realizing the codependency which this pandemic has highlighted. For instance, we take people out of hospitals, reducing the pressure on the NHS and look after them at home. The more we can do that, the less the pressure has been on the NHS. And that's been both the residential sector and the care at home sector. Rebalancing of funding to enable longer term resilience. It doesn't cost very much to get social care back on a better footing to do the job. The huge focus on the NHS has been very, very important, but I believe that it needs to be a rebalancing towards social care as well. And the most important thing to me is focus on raising the status of social care workers. In my last 20 years, I think the status of social care workers has lost ground compared with other professionals, healthcare professionals, and that's quite important. And the recognition, it's more than just a badge, and I have a badge, and I think that is good recognition, but it must be matched by funding for developing the workforce and enabling long-term career progression. So as a provider, the technology has been incredible. I mean, if we hadn't had the investment over the last couple of years, I believe we would not have been as resilient. But going forward, we're going to build on that embedded technology and overlay some of the front-end applications. We've got some projects going at the moment. Focus on where we're good, and where we've got expertise to facilitate growth, because the market is going to expand as we have more people to look after. But never lose sight of the fact that this is a people business. We've got to be good at caring and be competent and have empowered teams and teamwork if we're going to be one of the best. Technology is that essential enabler that can play an increasingly central role, but the focus has to be on our people. And therefore, it's important we engage in market shaping and influence the political direction of travel, focus with commissioners on removing unacceptable practices which basically don't allow careers to happen. The pay-per-minute billing I mentioned earlier, to me, is one of the things that going forward, if we're going to have a resilient social care sector at home, is something that needs to go.
Jonathan, sorry, I didn't mean to rush you.
Yes.
Thank you very much indeed. And look, I think from my perspective, that is a very useful setting of the scene as a provider. I think though, if I look at my home care, you're in the luxury position of being able to invest in all that amazing technology, and you have been doing for the last couple of years. Jane obviously represents the broader sector, and as we saw from William's slide with the size of providers, there are a number of them that are smaller and perhaps can't afford that digital technology investment today. And Jane, I'd be very interested to hear from you how the broader sector is coping with what's going on.
So thank you, Henry. Today I'm going to talk about why I think home care needs to be centre stage in a national social and healthcare strategy for COVID-19 and beyond. So picking up on some of the themes that Jonathan has trailed. People want to live well and independently at home, and the majority of them do. Carers UK estimates that anywhere between 7.3 million and 8.8 million people are supported by informal family carers at home, quite often receiving a bit of formal support to keep them all going. Age UK estimates that 1.5 million people need care and support at home and aren't receiving it. And we at UKHCA estimate that just under 1 million people are receiving formal home care. So in total, roughly 10 million people receiving or needing home-based support and care. And this contrasts with only 0.5 million people in hospital and care homes at any one time. So the numbers are very significant, but the entire focus of government and the media is on the 500,000 rather than on the 10 million, and we need to change that. And care homes, as Henry said, have only come under media spotlight because there have been deaths. Otherwise, it's all been about acute care in hospitals. And despite the fact that 10 million people need or receive support and care at home, government spend on home care is only 6.2 billion per annum across the UK, compared with 152 billion for the NHS. And there are roughly 1.5 million home care visits a day from the formal system, 70% of it roughly state funded, as William said earlier. Next slide. But scientific evidence shows that it's the social determinants of health that have a much greater effect on healthy lifespan than on healthcare per se. Having enough money, a decent education, good quality housing, nutritious food and drink, social connection and relationships, purpose and meaning, the right work, paid or unpaid, and physical activity is probably the single most important determinant of how well people age, and also lifelong learning, because exercising the brain, as it turns out, is also really important for maintaining cognitive function. All of these are things which home-based support and care can provide. Now, if anyone was watching BBC Breakfast on Tuesday, you will have seen a report about home care starring Colin Angel, our policy director. But in this, we heard from Pat, who receives home care, and she talked about how her home care workers cheer her up and how she couldn't possibly manage without them. And people like Pat, if they didn't receive that home-based support and care, they'd have to sell their houses and go into a care home, or worse still, end up in hospital. So next slide, yeah, if only 25% of the people that are currently on the delayed transfers of care list waiting for home care could be moved back home with support, the cost would be 424,000 a day, and that's at a fee rate that we consider adequate, not what most local authorities are paying, in contrast with a cost of 2.9 million for the NHS. So as Jonathan said, home-based support and care is a very cost-effective option. And in COVID-19, doctors in Italy, where this photograph was taken, have argued that home-based support and care would actually be a better approach in a pandemic than focusing on acute hospital treatment to the exclusion of everything else. They wrote a paper, and in it they said, home care and mobile clinics avoid unnecessary movements and release pressure from hospitals. Early oxygen therapy, pulse oximeters and nutrition can be delivered to the homes of mildly ill and convalescent patients, setting up a broad surveillance system with adequate isolation and leveraging innovative telemedicine instruments. This approach would limit hospitalization to a focused target of disease severity, thereby decreasing contagion, protecting patients and health and care workers, and minimizing consumption of protective equipment. So this is to build, we entered this pandemic in a weakened position, with only 1 in 7 councils paying the UK Home Care Association's minimum price for home care, which is the amount we calculate to be needed for compliance with national minimum wage, compliance with care regulations, and covering the other costs of running a business, like running payroll and invoicing and so on, with a small surplus of 3%, which is low by any standards. What we've actually found is that COVID, next slide please, Henry, COVID-19 has resulted in high exceptional costs, particularly PPE and staffing. Work we commissioned by independent consultants indicates that extra costs amount to £3.95 per hour of home care delivered at the moment, and there's no guarantee that those costs won't continue to rise. We've also conducted research on what councils are actually currently paying for home care, both to cover the national living wage increase and to cover COVID-19 exceptional costs. And our research up to the 7th of April showed that the median fee rate for home care was £16.96 per hour against the UK HCA minimum for this year of £20.69. Then on top of that, you've got another £3.95 per hour on average for the exceptional COVID-19 costs. So we're currently about £7.68 adrift from the amount that we believe we need to cover costs of home care. So going forward, what we need is adequate investment in home care to enable prevention, to reduce unnecessary admissions to care homes and hospital. We need to value, recognise, train and develop the workforce, as Jonathan said. We need innovation, both in terms of operating models and technology, and that's technology to support citizens, technology to support carers, and technology to support care operations. We're beginning to see those different elements coming into the market, but not yet in a very coordinated fashion. And we need transformation of our strategy and our system to put home care, home-based support and care centre stage, rather than being an afterthought.
Jane, thank you very much for that. I think when we were talking earlier, Jonathan mentioned his costs have gone up around 23% as a result of paying for additional PPE, covering absences among staff, which is actually very consistent with the data you've got for the sector. But as you saw from William's slides, if your margin is in the sort of low to mid single digits for the sector, that puts enormous pressure on providers to carry on delivering services without being paid more by local authorities. Our next speaker is Bhavna Keen Rao, and Bhavna is very much at the coalface in terms of helping providers to deal with the Care Quality Commission and improve quality. And Bhavna, over to you to give us your perspective as well.
Thank you very much. Good morning, everyone. I hope you're all safe and healthy. I wanted to talk about some of my experiences over the last few months, and one of the things that we have seen is that a number of our clients have come back to us and have spoken about the fact that they haven't, overnight with the lockdown, they had a reduction in services being withdrawn, so they couldn't take some of the clients that they were commissioned to take out to cinemas, pubs, etc. We know a number of clients have said to us that they've had a reduction by almost 40%. They are nervous, they don't know what the world will look like afterwards. You know, we talk about the new normal. The new normal seems bleak to some of the people because we don't have any clarity. So there's been real issues and concerns about where does this take us, and so social support workers are largely being withdrawn, and they are worried. So and lack of money coming in. We've seen charities like, you know, care workers charities supporting various grant aid for people not to be made homeless during this time. These are real tragedies. We've also heard of cases where clients of loved ones, so people's relatives, people who are in lockdown with their relatives, being asked to assist with moving and handling, supporting with care, which is quite worrying, where they haven't been trained, and this could lead to various other issues. There could be falls, there could be various other things going on. So we know that's happened. Care and supported living settings are requiring a higher amount of PPEs, but we know that there are real issues. 3 weeks ago, I've been saying to people, I was driving around all over the country asking various clients to donate some PPEs so I could take it across to other clients. That's not norm, and that's due to lack of clarity from local government as well as central government. There was lack of clarity about what PPE people should be wearing. That's led to various people being very anxious. We've had staff who've rang in and said, well, you know, I'm really worried. We have had people self-isolate. We've had other people who've come in above and beyond. So it's a mixed bag, and we've got GPs who've been not willing to go and make house calls. So all of those things have led to very uncertain times for various people who've received care within their communities. Next slide, Henry. So with increased difficulties in staff attending calls, we know that a number of packages have had to be given back. These are smaller providers given back to local authorities. We have seen local authorities pick these packages up. We have seen local authorities try and support some of the care providers with their care packages. But I think that's a real challenge. And I do think that had it been thought through properly by local authorities and supported some of these providers to support care within people's own homes and within the communities, the joined up effect of it would have been far greater. And I think, you know, it's a missed opportunity. There have been challenges, and we've been asked to support people with contingency plan. CQC local authorities have gone back to home care agencies and supported living people and said, we need your contingency plan. Everyone has a business contingency plan at the point that they were being registered, but nobody had expected, I mean, even the government hadn't expected a pandemic. So we need to be working with people. And I think that's, again, a missed opportunity. Rather than dealing with the stick, it would have been better had they had a template that they circulated instead of having people. And we've done a number of templates, and we've sent these out to various clients because we feel it's the right thing to do. We haven't charged for it because I just think this is awful time for everyone, and we need to work together. So again, I think there's been a real missed opportunities, and we know that, you know, local authorities have sent in some of their managers into some of the services to support, and they've had loads and loads of PPEs in their cars and stuff. And we know that it's been diverted. I mean, Jane's mentioned, you know, PPEs have been diverted to the NHS much more than, you know, with the home care agencies. I think these are real challenges. We know also there's been a huge increase in number of safeguarding notifications being raised. And that's really unfortunate, because in the current climate, managers, staff, they don't need additional pressure. I really believe that people work to the highest level. They want to do the right thing. We've got people clapping every Thursdays, etc. We are in a bubble. We're trying to do the best with what we have. And I think sometimes the local authorities and CQC have not been so present in support, but it's been quite negative. I'm hoping it'll change, but my worry is that these safeguarding alerts deter managers from doing the things that they need to do. We have issues, we need to get on, we need to work, we need to contain what's happening. Media, I think there is a real negative edge towards care homes. We know a number of providers within supported living as well have been asked questions. How do you try and make sure people aren't dying? Ask that to the central government, not, you know, various single individuals. And I think that's narrow-mindedness. So, and where you are being provided and it's been pitched against NHS, I think actually the social care and NHS, so health and social care, is one coin. It's one coin and two sides, and I think it should have been much more joined up. I think government, central government, are looking at that now. What a shame it took this many lives to come to this stage. But hopefully we will see something much more joined up. We are seeing more support being put in place, DNs coming out and supporting carers. Hopefully that will, and that's the green shoot for this dreadful pandemic.
So, Adna, we've got a question on Slido, which is asking whether the Care Quality Commission will adapt to this new world of technology. And as a former Care Quality Commission inspector, I just wonder whether you could share your view on whether they will move with this move towards more digital delivery, online training, etc., or not.
Right, so 3 years ago I did an article. So I left CQC following 23 years. I left 10 years ago and we set up the consultancy. 3 years ago I did an article to say we really need to think about a more modern approach to regulation and the modern approach to going in and inspecting. I really think digitalized way is, and technology is the way forward. We used to do that many years ago, where there were issues about 20 odd years ago. We did off-site visits. We had aquas and, you know, so many information coming in. They're going to try and do that now. And I think the lack of CQC intervention presence currently has led people to say, well, what is the role of the regulator? We've managed thus far. And I think the regulator has to change. I think they do have to start thinking about using technology more. If they can do it now, where they can have access to digitalized care records, or have access to CCTV. Most providers have these. I think it is a way forward. I think the regulator needs to rethink it. And I think the current climate being what it is, central government will be looking at that. So I think technology has a huge part to play in the modern way of living. And I think regulation has to adapt to that.
Thank you very much indeed, Badra. And that's a nice segue from regulation into the legal environment. Tom, I found this article this morning in the paper, which in some ways sort of flags up some of the key issues that people are starting to think about. Abandoned care homes warn councils of legal action. Care home managers have questioned whether local authorities should face corporate manslaughter charges. So it would be very, very interesting to get your take on where some of these regulatory and liability issues lie.
Yeah, good morning, everybody. This an interesting, if sad, observation. I'm not entirely sure how corporate manslaughter charges being raised against the local authority would actually work, but certainly that is a concern that operators should have, given that we're dealing with a deadly virus. I don't know if you want me to discuss that any further, Henry, or if you want me to move on to the slides. Is that where you'd like it to go?
Entirely up to you, Tom. We can move on to your slides.
And I'm certainly happy to come back on to what you've picked up this morning later on, if you wish. Just a brief couple of legal points which are circulating at the moment, and one very obvious one is, what if there's not enough PPE to provide the care? So far as I'm aware, this eventuality has not yet come to pass, albeit some employees have attributed different interpretations to the government guidance. And it is a scenario that has been in contemplation by a number of operators. Certainly, if it is not a risk an operator has assessed already, then now would be a good time to do so. The key consideration for operators are contracted to perform tasks for which they are unable to provide employees with the required PPE is the safety of both the employee themselves and the recipient. Accordingly, it would be most likely that the correct course of action would have to be that the relevant care could not be given if the requisite PPE cannot be provided. Were the care to be provided in respect of an individual who was in isolation and that person were to be infected with COVID-19, then it would be hard to view the situation as being anything other than a breach of health and safety, with the potential penalties on the corporate provider and on the directors of the corporate provider, including fines and imprisonment. In the case of COVID-19, in any risk assessment, the potential for a charge of manslaughter, corporate manslaughter, would need to be considered. And I think that ties in very well with what's being considered this morning, albeit I'm viewing it the other way around. The course of action whereby care, which was supposed to be given, is not provided, will probably impact on the contractual arrangements of the provider with the commissioning authority. I am aware of various threats being made by commissioning authorities in respect to fulfillment of obligations under contract, but nothing beyond that. Such threats are ironic, seeing as it would appear to be government bodies that are sequestrating much of the PPE that is available and making it unavailable for private operators. Whilst it is certainly the case that circumstances have changed and that those circumstances are both material and adverse, it is not a given that such a material adverse change provision will even be contained in the contract and thereby allowing operators a route out. Instead, we would probably need to look at how the contract might have been frustrated. Accordingly, you need to look at the minimization of the litigation risk. There are a number of steps that should be considered, and in doing so, the key thing is to document it all out. If it looks like a breach of contract is a serious piece of possibility, then discuss with the commissioning authority, put it back on them, ask for their help to avoid that breach, and indicate what percentage of services could still be provided, as opposed to simply saying the contract is fully frustrated. Perform a formal risk assessment of the possibility arising and consider that assessment professionally stress tested. Try and have the document show that everything that could have been done has been done. This process should also be done with an eye to the possibility of negative media coverage, as it may well be in the offing. It is possible to mitigate the impact of this if it can be shown that assessments were undertaken and by the deployment of appropriate professional advice. Just move on to the next slide. Thank you. I thought it was also appropriate just to have a look at a number of the legal issues in respect of the financing, as a lot of stress has been put on the finance side. There has been a potential change to directors' duties in respect of approaching insolvency, and the measures are intended to apply retrospectively from 1st of March 2020 if they come in, and they would apply for a 3-month period. The aim of the change is to encourage directors to continue to trade during the pandemic by a temporary suspension of wrongful trading provisions. Ordinarily, a director is under a duty to act in the best interests of the company and the shareholders as a whole. However, where a company approaches insolvency, these interests change and the interests of the company's creditors take priority. At that juncture, directors have a legal duty to act primarily in the interest of the company's creditors instead of the shareholders. The idea is that this obligation would be suspended, but there is no intention to suspend any other duties, and advice should be sought to ensure continued compliance. So in addition to directors' duties, we've also had a large number of inquiries in relation to potential events of default under lending arrangements. And we've seen many instances of businesses either breaching or anticipating that they will be breaching their bank covenants. In the majority of these cases, it is our experience that we have seen banks have been, by and large, supportive, and they've been offering that they can give payment and or repayment holidays, as well as waivers in respect of events of defaults, undertakings, and compliance with financial covenants. The key thing in respect of those who have been successful has been early engagement with the funder, allowing the relationship manager plenty of opportunity to get on your side and take the proposal through the credit process. You will also no doubt be aware of the many government schemes in respect of C-bills and CL bills. If these government-backed schemes have not already been explored by you, then we would obviously suggest that they should be, even if they prove to be unsuitable to your business. A point to note in doing so is that the government backing is to the lender. In order for the bank to have the backing, then it must ensure that the loan meets the requirements. The point being that some form of process akin to a credit process is required, and it should not be assumed that if the loan is sought, then it will be forthcoming. We have noticed that this arrangement has resulted in some rather fraught engagements between funders and borrowers. If you have any further questions on any of the above, you please let me know.
Thank you very much indeed for that, Tom. And look, I think there are a lot of moving pieces from a legal perspective. We have had a lot of questions coming in while we've been presenting, and I'm now going to hopefully share the question screen with you. So I think some of these questions actually relate to more of the supported living aspects as well. And I think from that perspective, William, I don't know when you've been talking to providers or indeed Bhavna, whether you've got any sense whether people in the supported living sector looking after people with learning disabilities are also encountering difficulties with service users. or whether it's different to the domiciliary care market. William, do you want to go first? I'm just going to unmute you.
Have you unmuted me? Yes. Henry, I think that the nature of the service is very, very different, because people with learning disabilities are typically receiving supported living, which doesn't involve personal contact. So they're less likely to be at real risk from infections. And they're also, of course, younger people, so they're unlikely to suffer the same consequences as older people receiving home care. So I think by and large, the problems have been less so in supported living, although they do obviously suffer from the problems with staffing as well, because people are isolating, staff are isolating themselves as much as people in home care are. So less so, but still some.
Bhavna, anything to add to that on your side? You speak to a lot of operators across the sector.
We've seen a number of challenges for the supported living providers with the various, being able to take people out, providing, individuals with the care that they require, and especially with people with autism or learning disabilities as well, how they're being able to self-isolate, keeping them indoors, and those are the biggest challenge we've seen. And the restrictions are still very much there, not being able to see their loved ones. The technology is there, but face-to-face contact, we've seen a number of families being very traumatized by that as well.
I think, Tom, just to come back to you, we've got a couple of questions here that are really partly commercial, partly legal, around whether COVID is force majeure, but also can providers claim business interruption relief as well. I suspect this is probably quite case specific, but on the face of it, if COVID isn't force majeure, it's not clear to me what is.
Absolutely, it's a very pertinent question, and you're right, it does turn on the circumstances, but the question, whoever put that question, they're absolutely right. Go take the whole circumstances to your advisors. There's certainly something to investigate there. It would be worth. I mean, I'm sure that question is not being asked in isolation. There'll be a reason that they're asking. Is it this? So take all those circumstances together to whoever's helping you with that, and ask them to address that question in the full.
I think one for you, Jane, because we touched on people essentially creating care homes on the cheap by using hotels. I mean, is your sense that is very much a temporary measure, or is that an attempt to keep costs down as well?
My sense is it's very much a temporary measure. I don't think it's necessarily a particularly wise temporary measure. The goal really should be to get people home where possible first. And live-in care, for example, is a very good model in this situation, because the care worker can self-isolate with the client, and the live-in care community have seen very few cases of COVID-19 amongst the people that they're supporting. I'm concerned about the hotel model, because I think they're recreating the conditions of a care home with communal living and, as we've seen, easy ability for the virus to spread, but without the resourcing that you typically have in a care home. So the contracts that were tendered that I've seen, for example, required one care worker, live-in care worker they were advertising for 5 residents. But there was no sort of kitchen team, laundry team, cleaning team like you'd normally have in a care home. Those care workers were expected to do everything, 1 to 5 residents. So I don't think that is a good idea at all.
I think just bring you in, Jonathan. There was a question earlier about whether there's actually any attempt here to actually engage about a combined health and social care strategy. You mentioned in your talk that it's sort of raised the issue in as much as made it very clear that the two are very interlinked. But I think both large providers like yourself, and also Jane with her sort of association hat on, is there actually any interaction with government on this pretty key topic, or is it all still words? We've been talking about this forever.
That was going to be my line as well, and not being party to what goes on in government. But I think that hopefully the COVID-19 pandemic will amplify the need for a joined up, cohesive approach to a combination of health and social care as part of the same solution long term in order for us to move forward. It is a hope and a wish. I've been around long enough to see at least 5 or 6 different attempts at a green paper and going to a white paper. And until we do have a cohesive approach, I'm not convinced that the whole government political will actually be put into action.
So shall I follow that?
I was right. Going to say, Jane, next up, but also I think, could you just explain to the audience what you've been doing in terms of participating in the various steering committees with government to try and raise the profile of what's going on in social care? I think that would be very good context.
So I think to get to the start with the initial question, the short answer is no, they're not really thinking long term at the moment. It's day-to-day firefighting. And to be fair to the civil servants, they usually don't find out what's going to happen until one of the politicians makes an announcement on the press conference every day, or at Prime Minister's question time, as happened yesterday when the Prime Minister announced they were going to ramp up testing to 250,000 a day. They haven't even managed to implement the 100,000 properly yet, and are estimating it's going to take another 4 to 5 weeks to enable all of the people that the politicians say can be tested to be tested. So it's a real challenge for everybody in government. What we've been involved in is that there was, I think the first meeting was on the 6th of March of a national adult social care COVID-19 planning group. And that's got members on it from all across government. So it's led by the Director for Adult Social Care at the Department of Health and Social Care. And there were representatives from NHS England, Public Health England, CQC, Local Government Association, ADAS, MHCLG, you know, all kinds of different people, provider representatives and so on. And then that sort of spawned a whole range of different work streams. So there are work streams on PPE, on testing, on workforce, you know, you name it, there's a work stream on it. There's also a huge amount going on technology as well, led by NHSX. So our life has been literally going from one call to the next, participating in all of these different groups and trying to get home care at least, you know, considered. And usually, I mean, the level of the sort of general lack of understanding across government is really quite extraordinary. I mean, they've just about got that care homes are something to do with social care, but they haven't yet seen that home care is. So last week, for example, we just heard that somebody had made a random decision to stop the rollout of NHS mail to home care. Nobody knows who that was or why it was done. So then, you know, spend several days trying to get them to reverse that decision. So that's, you know, we spend a lot of time trying to stop things from happening as well as trying to get the right things to happen.
Just coming back to you, Jonathan, as an operator, you mentioned when we were doing the rehearsal for this that you had personally just acquired several tens of thousands of gloves. And I think people are really trying to work out, where do you buy PPE? There are all these websites, there are stories of people being effectively, you know, ripped off or provided with PPE that doesn't actually meet the right standards. We've got one question here about what are provider experiences with websites like Edge for Health and PPE Exchange. Where are you acquiring yours?
I think to date we've probably used about 25, possibly 30 different sources, never in the amounts we used to be able to buy before. And it is about constantly trawling the market and making sure we're ahead of our need. At the moment, we have stayed ahead of our need, and we have never had a situation where we haven't had the PPE before we provide care service. But people are right, there are profiteers around. There are people who have set up as sort of middlemen in the PPE market. And all I can say is you've got to do very quick due diligence on all these kind of people. And one of the things we've tried to be very clear about is getting the supply that is already in the UK. Often I've heard one or two horror stories of people buying from overseas only to realize that the export license from that country is not available at the moment because that country needs it themselves. So yes, it is a problem. I think it will ease, but I did say that I think this is going to be an embedded higher cost for the whole sector for some time to come.
Can I just come in here, Henry?
Absolutely.
Right. So, and the worst case scenario that people are running very low on PPEs. Local authorities do have a number of PPEs behind the scene. They will be able to get them to you. Don't do what I was doing, running around all over the country while they were sorting themselves out. There is facilities, email them, bombard them, but you will get some support. They do have a stash of PPEs.
Can I come in here, Henry?
Please.
Yeah, because I think it's important that people understand what's happened here, because there's quite a lot of commentary on social media and in the newspapers about, you know, why can't these greedy private providers sort out their own PPE? So right from the very beginning, in the beginning of March, normally home care providers have their own suppliers of PPE from whom they get regular orders and regular deliveries. And in March, it became apparent that those regular supplies were not available, and the business as usual suppliers were informing providers that they'd been told to direct their supplies to the NHS supply chain. So we went and complained to the Department of Health, and they said, oh no, what's in the NHS supply chain should be for social care providers as well. So our members went off to talk to them, and they said, sorry, we can't help you because you're not NHS providers. Go and talk to the National Supply Disruption Response. So people went off to talk to them, eventually managing to get through sometimes after 2 weeks. And they said, really sorry, we can't help you. You're not an NHS provider. Go and talk to your business as usual suppliers, who of course had all of their stuff moved into the NHS supply chain. So we went back and complained, and then the government decided to do emergency drops of PPE to the local resilience fora. And we said, well, that's great, but who are these people? We haven't got any contact details. It took 4 weeks to get a list of contact details out of local government about where people should get stuff from. And even now, some people are not managing to get anything out of their local resilience fora. So then the government decided to designate initially 4 wholesale suppliers to focus on social care. And we told them that 4 wasn't enough because it would sort of blow all of their, their ordering systems, and most of them weren't taking orders from people who weren't their existing customers. Now there are 11 wholesale suppliers, but even like last week, some of our members were phoning them every day, and we're still unable to get masks. They had a delivery of 15 million gloves last week, which is why Jonathan managed to get some gloves for his business. But it's just like a constant battle. But what the government has done, they've got the Cabinet Office, a huge team at the Cabinet Office. They've had over nearly 20,000 offers of PPE supplies. Nearly half of those were from these middlemen that Jonathan talked about, where, if you look them up on Companies House, the company's been open for 3 days and they're all very dodgy. So they've got about 5,000 suppliers that they think are not so dodgy. They've also got 500 British manufacturers now making PPE. So we hope eventually that things will ease up. But they've also created an online dedicated PPE platform. The software is being written by eBay, and Clipper Logistics and UPS are providing the logistics. But that looks like it's about 3 to 4 weeks away from opening, because they haven't got enough supplies to put in there. So there's a lot of work going on, but it's not yet delivering on the ground in a reliable, consistent fashion.
Jonathan, I'm going to turn to you, because a lot of these questions are very much for a provider, in terms of people being effectively scared to enter a care home, or perhaps scared to let carers come into their home. And I know you mentioned your complex care business in particular, the referral pipeline is effectively stopped. What do you think we need to restart that? Is it just confidence, or is it the government relaxing the lockdown provisions, or a combination of the two perhaps? But clearly we want the system to start flowing again.
I think there are 2 different things. On the complex healthcare at home side, obviously it is about safe discharge from one environment to another, and how that can happen a serious period of overlap when hospitals are no-go areas for non-hospital workers is the difficulty there at the moment. But we are working on schemes to try and improve that and find a way to potentially do that overlap in the person's own home after the event. So that has been a specific issue. I think elsewhere, during lockdown, a lot of people have had the opportunity to be looked after by family members who may normally have been out of work or whatever during the days. And that certainly has slowed down the referral rate because people feel that there is no need to bring what is in essence a stranger into their homes over this period. Our sense is that as lockdown eases, we are going to have some of the people who have been self-isolating come back into our service because they're basically sort of parked, saying we don't need service at the moment, and also an increase in more clients coming through. Combine that with the relaxation in the NHS on non-COVID related procedures will also give a natural increase to the flow coming into both residential and social care at home.
Can I just add to that? There's quite a lot of work going on in the Department of Health looking at the needs of people who've had COVID-19, are in hospital and have survived, but will kind of have complex long-term repercussions from that, and what sort of care and support is going to be needed to look after them back in the community. So I think that will be another source too.
I also think that there needs to be a bit of work around the PR side. So people are terrified of going back into the care home, and I notice it's one of their questions. People are terrified of going into care homes because care homes are where people are dying. But I think the flip side will be that there will be an increase, I think, in providing care in their own homes or supported living. I really do.
Yeah,
So
we've started to see a large increase in interest in the live-in care model, where one care worker lives in with someone on a longer term basis. Yeah.
I think we're pushing for a kind of enhanced health in home care model. So there was some work previously on enhanced health in care homes that never really got rolled out properly. Care homes are getting focus at the moment because of their particular issues, but we're pushing very hard for that same thought process, and this is where, you know, some of the technology that I mentioned earlier could also play a role. Health monitoring apps, means of communicating with people remotely and so on, but obviously quite a lot of people don't even have Wi-Fi, so there's substantial attention to the digital divide that needs to be resolved before this could be widespread.
William, a question for you. As we look forward to where the market might go, there's a question here about whether you think there might be demand that will sharply increase just because people have been locked down in their homes, and linking with the previous question, have been scared perhaps to have home care workers come in, or indeed to tie it into supported living as well. Perhaps also the referrals into a supported living environment have stopped because people are unable to assess service users and admit them in the normal course. Do we think we will see a COVID bounce across both home care and supported living?
I think we'll certainly see a COVID bounce in home care for private payers because they potentially have the money to pay. Whether or not there's the same bounce for local authority funded supported living and home care, I would doubt it, simply since they are constrained by their budgets. So I'd expect the bounce to be principally in privately funded home care, together with the as Jonathan has mentioned, the new business starting up once the healthcare system starts to operate properly and referrals come down.
And I guess another one for you, Jonathan. You're owned by private equity, by Apposite Capital. Does this pandemic in some ways create an opportunity for the larger providers to continue to consolidate the sector? I think what we're hearing is, whilst there's a squeeze on the sector at the moment because you've got increased PP and staffing costs, over the medium to long term, there's a very strong argument that home care, there ought to be more of it, and it's raised its profile in a way that it hasn't in the past. Is there an argument that actually, more scale, more investment in technology, that momentum could be turbocharged by private equity platforms?
I think that will absolutely be the case for a couple of reasons. One is that even the largest provider in the care at home space has under 4% of the total market. So it's not as if there is anyone who you would consider dominant at this stage. And also for the larger providers, especially in the state-funded sector, and therefore it does sort of go over into the self-funded sector as well. It is important that you have embraced technology and become as efficient as possible and use the data you've got coming out to minimize risk, improve quality, and so on. And I think therefore that the larger providers who have private equity backers and the ability to invest in those platforms will be able to grow faster than a small provider. Personally, I'm a firm believer that there is room for the small providers too, doing more specialist or geographically based business as well.
So I think the question that's received the most votes, so 10, is really around technology, and I can't ignore it any longer.
Okay.
But I think I'm going to ask everybody, and because I think this is really a sector-wide dynamic, which actually is quite exciting in a way, because people are using technology, they're being forced to use technology in a way that they may not have done before. I think the best example perhaps is in primary care, where waiting rooms are often full of people of a certain age who felt they couldn't use technology, but by virtue of the circumstances of a pandemic have discovered they can, and actually it's not that difficult. So hopefully we've had the nudge that allows us to change the way that the market works and we deliver care. And maybe I'll start with you, Bhavna, just because you go in and see so many of these services. Do we think, or how do we think providers can actually engage with some of this assistive technology and actually make sure its adoption, and I think with your CQC hat on, how can we sell it to the regulator as the way forward?
I think we have seen a nudge, as you said, Henry. We are all engaged. When I was ill, I was actually given some very, very strong pain relief through just ringing up the doctor, and the prescription was at the supermarket, and it was here. So there was no issues at all, and I know that a number of people are seeing that type of interface with their primary care. We've also seen similar things with GPs using off-site assessment tools. DNs are doing something similar where they can, but they're only coming in essentially at the point where they need to physically see somebody. So we have seen a marked change in the way that people are being supported through assistive technology, and I think that that's out of the bag now. So the cat totally is out of the bag. We are going to see more of that. I think the regulator is going to have to step up. They are looking at some sort of methodology that enables them to use assistive technology to change the way that they function as a regulator. I don't think the legislation at the moment currently supports that. Because it's 10-15 years old, and yet 10 years we've seen huge changes in the way that we work. And over the last 3 months, I would say it's been significant. Since the lockdown, I think we've seen some really creative way of providing care, supporting people, checking and monitoring, and it's been really quite joined up. I mean, we've heard lots of negativity, but I think it's been quite joined up. If that continues and government doesn't get scared or is pushed into something else, this should be really positive for our sector. We've seen some really interesting stories, and I think we need those positive confidence to enable them to take on this new technology. And change is a challenge for a number of inspectors, and I think that training will have to come in. When I was part of CQC, when we went home working, it was a huge issue. Everyone does it now. So I think that's the challenge, and I think that's the way it's going to travel.
Jane, you're representing the sector and you're talking directly to government, lobbying on behalf of all your providers. What are your views on this, promoting technology?
So first of all, should say that about 1.7 million people are already supported at home by mostly alarm type systems. And 85% of those are sort of managed by local authorities and housing associations. In my personal opinion, a lot of that technology is a bit old-fashioned, and there is a lot of new approaches coming in that enable sort of technology platforms that connect different Internet of Things devices, allow remote health monitoring, remote communication, and so on. The NHSX has got a number of work streams, and I'm involved in some of those that are evaluating. They put out a call for suppliers to bid for funding, and for evaluation of their technology solutions. Quite a number of our members are already engaging directly with providers of these types of solutions. There's also the Technology Enabled Care Services Association, TSA, that's very active in this area. So I recommend that you go and look at their website. So if you're a provider wanting to engage and you haven't done so far, I would say go to the TSA, go to your local authority, because they've actually got people and money that can help. But I think we're going to see quite a big change and in a good way in the coming months and years. And if anything positive comes out of this awful pandemic, this may well be one of them.
So I think we're out of time, so I'm going to finish off with Jonathan as an operator. Although I put the poll back up, and I'm delighted to see that 50% of people think technology is the thing that will be most impacted by the coronavirus pandemic. So at least the audience is very much supportive of this question. But Jonathan, as an operator, what more can you do to engage, to push this theme?
Yeah, I think from our point of view, technology is absolutely essential, and for the reasons business-wise, because of efficiency and so on. But in terms of quality and providing a better overall service, using assistive technology alongside personal care is only a benefit to everybody. So I look upon the technology and assistive technology as a critical part of the offering going forward. It has to be funded, and if that's private pay or local authority, it's important. But it is an enabler, and I'll come back to, it enables the care to be better, to be more precise, more accurate, and so on. But you have to realize that this is a care business, and caring people are the people that this will enable.
Very good. Well, look, thank you very much for that. We are unfortunately out of time. You will be able to download the webinar and the slides from LaingBuissonEvents.com. So it just remains for me to thank our partners, Addleshaw Goddard, our content partner, Care Markets as a coronavirus toolkit, which we put together, and also our two charities. And just a reminder that our next webinar will be in a week's time after the bank holiday weekend, in partnership with Grant Thornton, focused on the adult specialist care market, which is clearly relevant because it also touches on the supported living market. And we'll develop some of the themes around supported living in that webinar as well. So apologies, we haven't been able to spend as much time on supported living as we might have liked. But thank you also very much indeed to all our panelists. And have a very good weekend.
Thank you.
Thank you.
Thank you.
Bye.
Yeah.